again, these are my disclosures. They haven't changed in the last few hours. I'm going to talk to you not just about rescue therapy, but about the different journeys that people take in ITP. And because that has a huge impact on what sort of rescue therapies might be useful or might be needed. And then I'm going to give you some examples before I finish, and you won't have to hear my voice again. So your doctors would tell you, or would probably write in their notes or their letters that, oh, you've got new onset ITP. And it makes pretty simple sense that if this is the first time you've ever had ITP, you've got new onset disease. You might hear the term persistent ITP thrown around when we see someone who's had that ITP last for more than 3 months. And then we start using this nasty word called chronic disease or chronic ITP when you've had it for more than 12 months. And I dare say most of you are probably living in that reality. But as doctors and even as people, does time matter that much? I think it matters more what treatments you actually need, not how many days ago you first had a blood test showing your platelet count was low. It probably matters more, do you need something now? Did it work? If it didn't work, what next? What do you need next? It doesn't actually matter that you ticked over from 2.5 months to 3 and a bit months. And a lot of you are familiar with some of these drugs like steroids, immunoglobulins, rituximab, thrombopoietin agonists, eltrombopag and avatrombopag and romiplostim. And you know that splenectomy is a dirty word, but it's an important word that still needs to be part of the conversation, because not only do some of you have that lived reality of having to have your spleen taken out in the past, it is still sometimes a worthwhile option to consider in certain circumstances for some of you. And it depends on your lifestyle, it depends on the tempo of your disease and where you're at. But of course, the harder your disease is to treat, the more your doctors might be thinking, is there something better? Is there something newer? And that's where clinical trials come in. Patients with ITP don't always follow the same path. These are 4 different graphs of what happens to people with multiple sclerosis, which is a completely different disease of the nervous system, but also from their experts in the field from decades ago, they never really seemed to bother differentiating between acute, new onset, persistent, chronic, based on timeline or how many days you had the disease. What mattered more in multiple sclerosis was, do you have disease that's sort of getting worse in spikes and before it gets a bit better, but slowly keeps getting worse in the background, so that's primary progressive or primary relapsing rather? Or do you have disease that's just never getting back to the baseline that it was every time it spikes up? Or do you have disease that's just slowly, inexorably getting worse? Or do you have disease that's relapsing and remitting with great big chunks of time in between every relapse? And in other diseases other than ITP, we're pretty good at talking about the journey that a patient is on, because that's how they decide what kind of treatments suit them better. We don't do that so well in ITP. But it's pretty clear that amongst you, even today, and sitting out there and having the honour of being able to hear your stories as we were consenting or in the clinic in the last week, with some of you in the audience, some of you have disease that's pretty stable. Platelet counts just sort of definitely diagnostic, definitely less than 100. You have ITP, but it's not getting worse, it's not getting better, it's just sitting there. Others, it's just slowly chipping away year after year, and it's just progressively getting lower and lower. And you're quite rightly be wondering what's in store for me next year. That's in contrast to others in the audience that I know who have disease that most of the time is actually pretty good. Some of you are sitting here with platelet counts way higher than the number of people sitting here in this audience, into the 200s. And you must be feeling like imposters being here at this meeting right now. But you know that every once in a while you have this terrible potential to drop your bundle and your platelets to be single digits and to end up in the hospital. We actually call these people chronic ITP just the same as the people who have a progressive ITP or as people who have a stable ITP. The words we use even in clinical trials as we recruit them is exactly the same. Do you have chronic ITP diagnosed more than 12 months ago with a platelet count less than 100? That's chronic ITP. But these people clearly are not the same people, are they? And then, of course, you have probably the most sinister type of sort of journey that you could take, where you're taking stepwise lurches downwards, ever downwards with your platelet count and never quite making it back up. And absolutely the future's not very rosy, or it doesn't seem very rosy. And what we use to rescue these situations are all going to be very different depending on which journey you're actually taking. And that's why so many of you can share notes about certain aspects of your disease, but try to get two people in this room describe exactly the same treatment schedule that they've been on. It's going to be really hard to find, is my guess. So when we talk about rescue therapy, or when we talk about patients with a progressive decline in their platelets, on-demand therapy, which is treatment which we usually use in order to prepare people for a procedure that might induce bleeding, that's only that might be the only time that we'll often sort of use some form of rescue. Emergencies are hopefully not too common, but definitely as the platelet counts get lower and lower, I think that feels like it's around the corner. But more than an emergency rescue, it's probably a long-term treatment that person's going to need rather than a rescue. It's probably going to be being onto something like a TPO agonist or a splenectomy or something to change the game, not just a short-term steroid fix for 5 days, not just IVIG. They're probably going to need something long-term. This is in contrast to people with stable disease, where you'd think, yeah, you might only need on-demand therapy as a rescue when you need to go in for a hip replacement, or when you need to, or if you're having an epidural, if you want to have the opportunity for an epidural if you're pregnant and you're having a baby. Sometimes, some of you, and as we all get older, we all pick up diseases, heart disease, strokes, atrial fibrillation. There might be situations where other doctors want to put you on a blood thinner or something to make you bleed. But it's not going to be easy to do that when your platelet count's still always really low. And the temptation will be from your ITP doctor to maybe make your platelets a little bit higher than what they might have been in order to be able to keep taking the blood thinner. Hopefully, we don't need emergency rescue, but there's a lot of unpredictabilities in there. Patients with stable disease usually won't need long-term treatment. And there are some of you here in this audience with a platelet count that's stable, somewhere between 40 or 80, and you're not on anything. Your ITPs, is it in remission? I'm not sure, but it's not needing any treatment at the moment. This is very different to people with relapsing remitting disease. It is very unpredictable. There are some patients I've had who would relapse every autumn. Some people who relapse with vaccinations, some people who relapse with great emotional stress. But the number of times I've met people with this sort of pattern who relapse For absolutely no good reason at all. It's just leaves me scratching my head. On demand is usually not needed. So if someone with relapsing remitting disease needs a dental extraction or a gallbladder taken out, the platelet counts are usually pretty good. We don't usually need to stick them on anything to keep them good because we can't predict when they're going to fall. They are the ones that need probably the most of this seesawing game with emergency rescue therapy of 5, 6, 7 days of steroids or maybe a few weeks of steroids and some IVIG to get them out of hospital and then suddenly get them back on the straight and narrow. These are the ones where long-term treatment's not usually needed, nor are these the ones where long-term treatments are even an option or available, and we don't even test anything in clinical trials with trying to break this sort of cycle with anything other than trials that look at upfront disease, trying to convert people from having ITP that hangs around forever, called chronic ITP, or ITP that goes away. These guys are obviously the worst in terms of what you might expect, where disease is just stepwise getting worse and sometimes in unpredictable leaps and bounds. And that is just as much of a problem as the platelet counts themselves. It's the unpredictability, and the uncertainty, and the anxiety that uncertainty produces. We don't usually need to give on-demand sort of therapy until towards the later stages, but definitely the emergency treatments are often needed with the relapses. And by the time they eventually get into a very poor state, these are the ones where, again, we'll probably have them on some form of long-term treatment. But what does rescue treatment look like? Rescue therapy. Are these rescue therapies?
Yes, yes, they are, yes.
Sorry, guys, a little bit more dull. These are the sort of rescue scenarios that I think of in my head. On-demand therapies, emergencies, refractory disease. Another scenario where we might want to consider rescue is when we're trying to treat a clot, and of course pregnancy-related situations. On demand is usually a very short-term burst of therapy. So when someone with stable disease or progressive disease or with platelet counts that are predictably low, when they need platelets a little bit higher, that's when we'll often plan around the date of their surgery and organise about a week or two in advance, either immunoglobulins, steroids, or even injections of TPO if you have a benevolent hospital with a formulary system, or if there's been some situation in the past where you could get access to romiflostim. Emergency situations obviously are a lot more dangerous and they last longer. They don't usually get better in a short space of time. And here we have to rely on a little bit more heft with our treatments. Pulses of dexamethasone. If you've ever been stuck in a hospital with a really low platelet count, you might have been offered intravenous steroids. Sometimes platelet transfusions, particularly at the time of any bleeding or if a procedure needs to take place then and there. And sometimes splenectomy is still performed as an emergency when people have got really next to nothing left to try to keep them alive. Vincristine is also another treatment some of you I know have had as a way of trying to quickly get rid of certain cells that might otherwise destroy your platelets. So these are the situations, these are the drugs we would use when there's either active bleeding or a very, very high risk of bleeding because the platelets have suddenly gone from 200 to 2. Patients with refractory disease don't have that same urgency usually. So these are those situations like with that progressive disease where the platelets might be inching lower and lower over many years. And eventually we might decide to start some treatment. The slide won't fit the long list of things that we can use, but definitely there's always some risk of bleeding when the platelets are that low. Um, but that's quite a different scenario to people with an emergency relapse. Sometimes, just sometimes, there are situations where we do need to raise those platelet counts a little bit in order to, paradoxically, increase your risk of bleeding or bruising in order to try to stop those platelets from sticking together too much in your coronary vessels. So we have certain targets we like to have as a minimum to know so that we could be safe in giving you aspirin or safe in giving you a blood thinner if there was a really good reason you're on that blood thinner. And obviously we always challenge that reason, because if it's just as safe for you to come off the blood thinner or come off the antiplatelet drug, that's clearly like what we would prefer to use. Pregnancy is another very important and very distinct situation where we have to tread super carefully because there are two lives at stake, not just one. Sometimes a slight preference to using immunoglobulins. I'll give you an example of that later. And steroids, platelet transfusions, even just at the time of delivery. And again, even splenectomy can be useful, particularly from the second trimester onwards. So these are all options. I'm not saying that they all have to happen, but definitely when the going gets tough, of all cases, it's the pregnancy cases that keep us up at night the most, probably. Particularly when we're wanting to make sure the pregnant woman is going to be comfortable and confident about being comfortable going into delivery. And that means ensuring they have access to an epidural if that's what they want, rather than trying to talk them out of it. So this is an example of a young lady who, this was like a second or third pregnancy with, I think the shading didn't come up again, who previously had a lot of bleeding with her past pregnancy. Had bleeding during this particular pregnancy and had intravenous immunoglobulins before, but got really severe headaches with them and just didn't want to have IVIG again. And I'm sure a lot of you guys here know what that feels like. So this was meant to be an example of a person basically having about 25 milligrams of prednisone for these weeks, about 4 weeks before being able to successfully deliver her baby without any bleeding complications whatsoever. Sorry, the shading didn't come through. This is an example of therapy where, again, there was some prednisone used in order to prepare a patient for abdominal surgery where in the past there'd been bleeding despite using steroids as a way of trying to, on demand, increase the platelets. And so in this case, we decided, no, we're not going to just do the steroids again and run the risk of bleeding. We're going to do both. And as you can see, it's not until we gave the IVIG as well that the platelets jumped up nicely, and then we were eventually able to come off the steroids. As long as it happens in time for the actual surgical procedure, that's fine. We don't need the platelets to be above 100 for months and months before and after a surgery. We just need it up for that time of greatest risk. And once it's done, great, we can stop. And we don't need to expose them to extra steroids or expose them to extra IVIG. This is an example of a lady who really wants to retain her opportunity to have an epidural if needed. And what we'll often do is, as they're getting closer to the estimated, in this case it was induction when she had a baby, we would plan to give the IVIG about a week just before, and her platelets went up beautifully. We could do this because we'd practiced this in the past. We'd rehearsed this earlier on in her pregnancy. We knew that she'd get a good response. And that's often a neat trick to consider if that ever becomes relevant for you. And this is another example of a patient getting ready for bilateral knee replacements. In this particular case, she hates IVIG because it always gives her the worst headaches. Steroids need to be at a really high dose for them to work. So we were able to get some injections of romuplastim, and we started them about 10 days, I think, before the surgery. The platelets had come up, but we just already planned we already arranged to have a second dose, so we gave her a second dose. And again, platelets were safely high enough for surgery. We stopped the romuplastim. They drift back to her usual level of about 40, 30, 45, and she doesn't need ongoing romuplastim, and she's got 2 new knees. And this is a patient, again, sorry, the prednisone shading didn't come through, but this guy was being prepared for a hernia repair, and I'd known him with stable ITP for several years, and his platelets were just always sitting around 30 for ages. This is a few years. But the surgeon wanted the platelet count a bit higher, so I stuck him on some steroids. I think I actually gave him a dose of 50 milligrams for a few days to try to see if anything would happen. Nothing happened. As you can see, all the way up until the date of the surgery, he ended up needing to get a platelet transfusion in order to get the surgery safely, which he did. It was just a hernia repair. He got through it. He survived without bleeding. But sometimes we try things and they don't always work. It's hard to predict. This is an example of using rescue therapy in a really difficult situation. And again, this graph doesn't show too well the prednisone that this guy was on, who happens to be in this room at the minute, giggling away. But he had a very high dose of steroids when I first met him. Platelets were still pretty poor, and we thought, wow, we've got to do something because the steroids, the prednisone wasn't working. So I pulled out some tricks from my bag. We gave him some rituximab and some high-dose dexamethasone. We even repeated the high-dose dexamethasone. That wasn't working. And so we put out the IVIG, and that finally worked. And the reason why I like this as an example is because it demonstrates how, as doctors, when things are looking really bad, sometimes we just have to keep throwing one trick after another until something sticks. And then eventually, in this case, the IVIG stuck. So we got him safe. Again, the dapsone doesn't come up clearly, but I put him onto dapsone as a way of not only reducing the risk of certain types of infections we call PJP, he's been on lots of steroids already, but also as a way of trying to keep the platelets a little bit higher. It started to lose its shine after a little while, and it was probably causing some side effects, some breathlessness and so on. So we thought, there's probably not a lot of extra benefit from staying on it. So we stopped everything. And his platelets just continued to decline further and further to a point where it just collapsed, like another little flare or another little relapse. And I think there must have been some bleeding for me to have been worried enough to give him some IVIG as well as another pulse of high-dose dexamethasone. as well as at this point, taking that opportunity to start a TPO agonist. And sometimes we have to wait for that in order to know that it's the right thing to do. So, we've gone through and told you about all the different rescue therapies we use in ITP.
You're not there.
I've given you some examples. I don't need to be there. You can just picture me already. Any questions? Any questions, anyone?
Yeah. So we're obviously the only pediatric in the room. So children, I'm mad enough. Children sit around 30, like that's our normal baseline. But as an adult, what's the difference? Because we're approaching that sort of phase where we're, inevitably should probably be treated as an adult. And for us, we sit at 30 and that's quite normal. So we don't need treatment, but she doesn't actively bleed. But how does that look as an adult? Because from what I saw up there and what I've seen on other people, they are in full treatment, but that's almost scary for them.
Yeah. Look, I think it is true that if you could find a level of a platelet count where you're not too fatigued and you're not bleeding too much and you don't need any surgery, why are we measuring it? You can sit there for ages, forever. That's where sometimes as doctors we're guilty of just worrying too much about the number.
Yeah.
What's your platelet count? What is it now? Oh, it's 27. Oh, it's less than 30. Whereas, as long as you're not bleeding, as long as you're not about to go through a procedure like pregnancy or a major operation or something like that, then we can just sit pretty at 30. That's fine. These days, the rules have actually adjusted a little bit. So, for example, to get onto a TPO agonist, your platelet count needs to be less than 20, or to be bleeding between 20 and 30. And that's probably more or less in line with what most of us do. Yes, please.
I'm also really reactive to steroids.
Yes. Yeah, so we've had that. She's had 10 teeth pulled out, so we had to a trial of steroids to make sure they worked, and then they worked really well. So, and then not long ago she just had a rhinovirus and it threw it to single figures, which we'd never been before. So, again, that's quite frightening. But, it's almost like we just go, oh, tick, yeah, got through that, no dramas.
Yeah.
So.
Definitely. Look, I wish and I hope that it sits at 30 and if anything gets better over time. But you just described that situation almost like a stepwise deterioration where it went lower than what it's ever been before. And, it is a challenge. We also know that over time, as people have a chronic disease that lingers on, it does for other people often get harder to treat. So for now, while we respond really well to steroids, I think that is great. That's precious.
Yeah.
Keep it, treasure it.
And I get one
Yeah, that is great because that would be like a great go-to when there's a flare or a relapse. It's sadly not the same experience for everyone. And that's again part of that patient journey where everyone's so slightly different.